Is there an optimal approach to preventing Crohn's disease? And this is an update really in 2016, 2017. So the natural course of postoperative Crohn's disease, we know that when patients undergo a surgical resection, for that split section, they're essentially cured of their disease. However, despite clinically silent recurrence, if you start to look over to the right, at 1 week, there's already histologic evidence of recurrence if you were to biopsy the normal neoterminal ileum. Going further to the right, there's endoscopic recurrence at 1 year, up to 90% of patients, and you see this in your practices all of the time. Patients undergo resection, they feel great, you do a colonoscopy at 1 year, and they already have endoscopic recurrence. Further to the right, there's tissue destruction, damage, and clinical symptoms that lead to the point that they need another surgery in about 50% of the cases at 5 years. So the question becomes, sorry, my slides are frozen. The question becomes, how do we actually proceed with the next step? So until recently, there's been no real post-op guidelines, but two approaches that we've looked at. One is early treatment for disease, and the other is endoscopic guidance to decide on treatment. And you just heard from Jean-Fred Colombel looking at tissue destruction and damage, and there's a tipping point by which we pass beyond which we can recover disease. So the earlier treatment approach looked at medications for preventing post-operative Crohn's disease. And this is a study or a systematic review we looked at in 2009, and it still somewhat holds today. So in the pre-biologic era, if you look on the left-hand side of the slide, placebo on the top left, 5-ASA, budesonide, nitro-imidazole, azathioprine, 6-MP, look at clinical recurrence and endoscopic recurrence. Interestingly, I think a couple of things stand out in this slide. One, look at the clinical recurrence for antibiotics, metronidazole and arnidazole. And I would challenge all of us in the room, and for those that are working on the microbiome, there's obviously something impactful about the bacteria in the intestine that play a role in all of inflammatory bowel disease, but certainly in post-op. The problem is when you stop the antibiotic, and many patients don't tolerate this, endoscopic recurrence is ultimately inevitable. The other thing about this slide, that if you look on the right-hand side with endoscopic recurrence and compare it to placebo, we don't see significant differences aside from maybe azathioprine and 6-MP where you see a trend. And the question is, what about post-op anti-TNF? So this is the study we put together in 2009 where we looked at 24 patients who underwent a resection, half were randomized to infliximab, half were randomized to placebo. And in this slide, which you've seen before, in red is placebo endoscopic recurrence, and yellow is the infliximab endoscopic recurrence. And we saw a large signal separation between the two in terms of endoscopic recurrence. So in 2009, when this study was published, it influenced the management of Crohn's disease, and our media center at UPMC, which is quite strong, decided that they would take the angle that this was actually a cure for IBD. So embarrassingly, at this meeting in 2010, Steve Hanauer introduced me as curing Crohn's disease. But the other aspect of this is if we can fit all 24 patients onto one bus as part of a clinical trial, should that really influence what we're doing? So one of my patients in an acute way, and some of you have seen this, came up with a Pittsburgh post-op bus, and he feels that I drive them around and still drive around these 24 patients because they're so coveted. But should we change practice based on this? And the other aspect to a bus in Pittsburgh in December is that when we think of a bus in Pittsburgh in December, this is who we're thinking of. So again, a Go Steelers plug. So there have been several studies that came out of that 2009 pilot study that looked in an open label fashion. Some were randomized, but really not controlled. On the 4 top were with infliximab in blue. The 6 in the bottom were with adalimumab in white. And what you can see in the middle column under anti-TNF for endoscopic recurrence, the endoscopic recurrence rates were trending to be similar, 0 to 20, 21%. And a take-home message, if you remember the number 20 to 22% endoscopic recurrence post-op with anti-TNF, that is probably the number. 20 to 22% endoscopic recurrence post-op anti-TNF at 1 year. So most recently, there was the PREVENT study, which was the large international multi-center study that was just published in Gastroenterology this year, looking at prevention of post-op Crohn's with infliximab. One of the primary differences between this study and many of the studies that came before were that the primary endpoint we set was a clinical recurrence, not an endoscopic recurrence. And some of that was influenced by the FDA in terms of labeling drug after post-op. So this was a clinical recurrence. So look at the left-hand side of this slide in the figure where you see a gray bar with 20% and an orange bar with 12.9%, and everybody always scans to the p-value, and no, this did not meet statistical significance. It was a p-value of 0.09. This is clinical recurrence at week 76. One thing I would state that the placebo value of 20% clinical recurrence, we all see this in our practices. The deepest remission is sending a patient to surgery, and they do well after surgery for a long period of time without symptoms. The secondary endpoint did meet statistical significance, and this is more or less what we're seeing. 51% of placebo patients had an endoscopic recurrence compared to 22% with infliximab. Again, that number of about 20 to 22% seems to be consistent across all trials and now the large PREVENT study. All right, so that was early treatment to prevent post-op Crohn's. But the question now is, what about waiting for endoscopic recurrence? And Michael Kam and his group put together this study called the POKER study. And basically, in essence, in what they did is half the patients had a colonoscopy at 6 months and then at 18 months. And the other half the patients had no colonoscopy at 6 months, but just an 18-month colonoscopy. Those that had a colonoscopy at 6 months adjusted treatment based on what they saw. And many of you in your practices probably say, you know what, I don't want to put patients on treatment, let's do a 6-month colonoscopy. And what they found is between the group that had a colonoscopy at 6 months, adjusted treatment for endoscopic recurrence, and those that had no colonoscopy at 6 months, there was a statistical improvement in those patients by looking early. So the main question still remains, when should we use, and this I put anti-TNF, but now there's a vedolizumab study that's about to embark, and certain other biologics we'll probably be looking at in the post-op model. Should we start everybody right away after surgery? Should we wait for endoscopic recurrence? And as Jean-Fred has shown us just a minute ago in looking at tissue destruction, if we wait too long beyond the tipping point between inflammation and scar or irreversible damage, ultimately patients will need surgery. So the question still is, what do we do, and are there guidelines? Well, just last month, in November of 2016, post-op Crohn's guidelines emerged, and these were published in Gastroenterology. This is electronically available. And along with Fernando Vallejos, I had the pleasure of leading a truly brilliant team of biostatisticians who looked at a technical review of all studies ever done for post-op Crohn's disease. And this is what I think we should use to inform our knowledge, because this is probably the best guidelines piece that we have to date. So just to back up, in terms of those that aren't used to looking at guidelines and how we grade these and technical reviews, we asked 4 clinical questions by PICO, Population Intervention, Comparator, and Outcomes. So the first question we asked, which is clinically applicable to all of our patients and us, is routine early postoperative pharmacologic prophylaxis superior to waiting for endoscopic-guided treatment? Meaning, should we treat immediately or should we wait for an endoscopic recurrence? So do we treat here or do we treat here? That was question 1. So the population of patients were those that underwent surgery. The intervention is early pharmacologic treatment in patients who underwent surgery within 8 weeks. Those are all the studies that were looked at that have ever been done on this topic. And the comparator were those patients who had an endoscopic guided treatment, and the outcome was reduction in recurrence over 18 months. So we wanted to try to look at least patients who had been followed for 18 months. Question 2. What is the comparative effective of all the agents that have ever been looked at for post-operative Crohn's disease up to the point of immunomodulators, antibiotics, and now anti-TNF? And you can't, and I don't expect you to read the little blue bubbles, but these are essentially cross-analyses that were done between multiple studies. So for this, we looked at patients who had an ileocolonic anastomosis in whom early post-op prophylaxis is being considered. The intervention was any of the agents. The comparator was a placebo or an active agent or no intervention. And again, we looked at outcomes and reduction of recurrence. We were also very interested in looking at adverse events. So how about what happens when we treat these patients post-operatively? So now, nothing to read on the left, just look at the red. I'm only showing you one of the samples of the technical review. But basically, we looked at endoscopic recurrence compared to placebo. And if you see all those black diamonds in a line that runs up and down on the slide, that's the line of unity. If the black diamond is to the left and doesn't touch that line, it means it favors the experimental or the treatment arm. If the black diamond touches the line, it means it's no difference compared to placebo or the comparator group. So we looked at 5-ASA and immunomodulators and anti-TNF. And you can see that the black diamonds start to creep to the left, and that suggests that immunomodulators, maybe we see a signal, but we see a clear signal with anti-TNF. And then we compared immunomodulators with 5-ASAs or antibiotics. We compared TNF with 5-ASAs and immunomodulators, and you start to see even a further separation of those black diamonds from the line. Question 3, is routine endoscopic monitoring at 6 to 12 months after surgery superior to no endoscopic monitoring? Meaning, should we look at 6 months, should we look at 12 months versus not looking at all? So again, patients who had surgery, the intervention was active management with routine evaluation of endoscopy at 6 to 12 months. The comparator was not looking at 6 to 12 months, so patients who just had long-term follow-up without the colonoscopy. And again, the outcome was reduction of clinical recurrence. And then finally, the fourth question was, in patients with asymptomatic endoscopic recurrence after surgical resection, what is the comparison of starting a medicine for endoscopic recurrence in terms of preventing a future recurrence? So essentially, wait for that endoscopic recurrence and then treat. And the question is, which medicine will prevent surgical recurrence and clinical recurrence? So that's the fourth question. So these 4 questions then informed the AGA guidelines. So for those that aren't familiar with this, the technical review panel puts together the evidence-based data, and the guidelines panel then takes that data to form guidelines. So these are the AGA guidelines, which I'm going to show you for postoperative Crohn's disease. First of all, why guidelines? And this was a quote from the study. These guidelines are intended to reduce practice variation and promote high-value care. So the grade definitions, not to take you through this too much, but you see these in most of the guidelines now, and to be quite honest, if a guideline doesn't have a grade analysis, it's probably not a good guideline. So the guideline grade would be high, which means we're very confident that the true effect lies close to that of the estimate of effect, and then it goes all the way down to very low. We also grade the guidelines based on strength of recommendation, strong versus conditional, and we consider the patient and the clinician. And this is true of most of the grade guidelines that have been done. So this is number 1. And I'm actually taking the direct quote from the guideline, and this is the bottom line. The AGA recommends early pharmacological prophylaxis over endoscopic-guided pharmacologic therapy. Now you can see this is a conditional recommendation, very low quality of evidence, but this is recommendation 1. So this means treat here, not here. Number 2, in patients with surgically induced Crohn's disease remission, the AGA suggests using anti-TNF and or thiopurines over other agents. So this is, again, a conditional recommendation based on moderate evidence. Number 3, in patients with surgically induced remission, the AGA suggests against using mesalamine, budesonide, or probiotics. So the question is, are those agents dead? This is based on the AGA guidelines. Number 4, the AGA suggests routine postoperative endoscopic monitoring at 6 to 12 months over no monitoring at all. So that basically means look at either 6 to 12 months, hope to pick up early endoscopic recurrence in those patients, then we can intervene. And then the final, patients with asymptomatic endoscopic recurrence. So this means you look 6 to 12 months, you find disease. The AGA suggests initiating or optimizing anti-TNF and or thiopurine therapy over continued monitoring alone. So those are the guidelines. Those are the guidelines that came out of the recent gastro article. So I think now the question is, how do we manage this? And we need to consider the recurrence for surgery. So the AGA also asked us, and they said, you know, one size doesn't fit all, and we see this in our practices all the time. So the AGA asked us to come up with what we considered low and high risk factors. And I think these are guidelines that we all follow in our practices. Now, one thing I want to be very, very careful in saying, these are not validated. We do not have the validated measures for predictors of risk after surgery. However, this is what we've accumulated from all of the data that's been looked at in post-op Crohn's, and then we came to a consensus. So a low-risk patient would be your patient who's over 50, non-smoker, first surgery for a short segment, less than 20 centimeters, and a duration of disease longer than 10 years. The hypothetical clinical recurrence based on calculations is about 20%, and the hypothetical endoscopic recurrence we calculated at 30%. How about the high-risk patient? That patient younger, less than 30, smoker, more than 2 prior surgeries, especially for penetrating disease, who may also have perianal disease. Clinical recurrence we estimated at 50%. Endoscopic recurrence, which has been shown by Paul Rutgerts and other groups, was estimated at 80%. So this then came up with a post-op algorithm, and I think this is what most people will look at when they read the articles. They'll forget all the mumbo-jumbo about all the statistics, and they'll basically go to this slide and say, what should I do in practice? And this is the algorithm that's put together. I'm going to show a clear algorithm in a minute, but I decided just to actually copy and paste. So this is surgically induced remission, low risk for recurrence, and the other important part of this, and I think Corey has influenced this, there are patient preferences and values that are taken into account. So a low-risk patient does not need treatment based on the guidelines, but should have a colonoscopy, and I would argue probably 6 months, but this says 6 to 12 months. And if there is recurrence, then use an anti-TNF or thiopurine based on our current data today. Now, if it's a high-risk patient, the guidelines suggest using pharmacologic prophylaxis with an anti-TNF and or thiopurine, and then nitramidazole is put in there based on the data that we have is for 3 months. If the patient has a colonoscopy at 6 to 12 months and then there's recurrence, the recommendation is optimization. Now, if it's a patient who does not want to go on treatment for whatever reason, there is the option to give nitramidazole antibiotics for 3 months and do a 6-month colonoscopy. So what does this all mean? After all of these years, and I was looking back to the first time I made this algorithm slide in 2008, and I actually don't think I've changed my practice very much based on the systematic reviews and the guidelines that we now have. So this is how I approach Crohn's disease in my practice. You've probably seen me present this before, and based on the guidelines, this more affirms what I'm doing than negates. So if they're a low risk for recurrence, that patient who may have had long-standing disease comes to their first surgery for a stricture, and they have had really no other complications along the way, I do not start treatment, but I do a colonoscopy at 6 months. In the era of calprotectin, I think it's very reasonable to consider a 3-month calprotectin, but I'm still using the 6-month colonoscopy to base my decisions. The moderate risk group, this is where I may differ a little bit from the prior guidelines, but this is how I think of patients in my practice. If it's a patient who comes to their first surgery within 10 years and they have active Crohn's disease at the time of surgery and they've really been on no treatment, I still would consider an antibiotic if they could tolerate metronidazole, and azathioprine or 6-MP. Now, as I stand here today, and I think this is changing over time, based on some of the safety profiles with thiopurines, I may change my practice, but today I would still consider an immunomodulator for this patient, but I think we can debate this topic and wonder, is that the appropriate approach? And then finally, for the high-risk patient, penetrating disease. And the number one risk factor to remember is if you have a patient who's had more than 2 surgeries, that's the high-risk patient that probably should get some type of prophylaxis. And I would argue this is a patient who in this era should get an anti-TNF. I put in combination with immunomodulators, but as Jean-Fred has said and Adam had shown us yesterday, maybe proactive testing with therapeutic drug monitoring would be the way to go. So that's how I still practice today. I think the AGA guidelines are important and helpful. They are now available if you go online, and thank you very much.